I've opened more than 2,000 chests in my career. I've held beating hearts in my hands. I felt the difference between a healthy heart and one quietly losing the battle for years. Some of the worst damage I've seen on that operating table wasn't caused by poor diet. It wasn't smoking. It wasn't genetics. It was caused by medications. Pills prescribed with the best intentions that were quietly working against the heart instead. I'm Dr. Kevin Adewale, cardiothoracic surgeon. 25 years operating on hearts that reached the point where surgery was the only option left. Today, 5 specific medications that millions of people over 60 take every day, and what the 7-minute appointment almost never covers. This is not about scaring you. It's about giving you the information you need to have a better conversation with your doctor. After 60, your body processes medications differently. Your kidneys filter more slowly. Your liver metabolizes drugs at a reduced rate. The average American over 65 takes 4 to 5 prescription drugs simultaneously. Some take 8 or more. Each drug was tested individually, approved individually. What happens when you combine 3 or 4 in a body already working harder than it used to? That question almost never gets answered in a standard appointment. I want to introduce you to someone. I'll call him Clarence, 74, retired electrician, sharp, careful, did everything right, walked 2 miles every morning, watched what he ate, had every reason to expect his health was under control. Clarence came to me after his second cardiac event in 18 months. Exhausted. Not tired, exhausted. The bone-deep kind that doesn't lift after a full night's sleep. Muscle cramps woke him at 3 in the morning. His thinking had slowed in ways that frightened him. 3 doctors. Same answer every time. Clarence, you're 74. This is normal. 2 years of that. When I reviewed his full medication list, every drug, every dose, I saw the problem within 5 minutes. Not one problem, 3. Simultaneously, for 2 years. We'll come back to Clarence, because how his story ends is the whole reason I'm making this video. Now, the 5 pills. Statins. If you're over 65 in America, roughly 1 in 3 chance you're taking one right now. Atorvastatin, rosuvastatin, simvastatin. The names change. The mechanism is the same. Statins save lives. For established heart disease, the evidence is clear. I've prescribed them thousands of times. I stand behind that. But there is a consequence buried on page 14. Statins block something called the mevalonate pathway. That pathway doesn't only produce cholesterol. It also produces CoQ10, coenzyme Q10. And that distinction changes everything. CoQ10 is the fuel your heart cells run on. Like engine oil, without it, the engine runs rough. And eventually, it wears down. A 2005 meta-analysis, replicated multiple times, showed statins drop CoQ10 blood levels by 30 to 50%. 30 to 50% depletion. In the organ that needs it most. In a real patient. Fatigue that doesn't respond to rest. Muscle weakness. Mental fog. Measurable reduction in cardiac function in a significant subset. Clarence had been on a high-dose statin for 2 years. 2 years of his heart running below capacity, and here's what should make you angry. CoQ10 testing is not standard practice, not in the guidelines. Some insurers won't even cover it. CoQ10 is over the counter. No patent, no profit margin, no financial incentive for anyone to add it to the standard protocol. I'm not calling it a conspiracy. I'm calling it a system with no incentive to ask an inconvenient question. The fix. 100 to 200 milligrams of CoQ10 daily. The Q-Symbio trial showed measurable improvement in heart failure patients who supplemented it. Should I be supplementing CoQ10 alongside my statin? That's the question. Write it down before your next appointment. Not should I stop, just that. Pill 2. This one surprises people. It doesn't look like a heart medication, and that's exactly why it's dangerous. Ibuprofen, naproxen, diclofenac. The NSAIDs, over-the-counter, cheap, in every medicine cabinet in America. Most people think ibuprofen reduces inflammation. Inflammation is bad for the heart, so it must be neutral at worst. That logic is exactly backwards. NSAIDs block COX enzymes, But COX-2 specifically produces prostacyclin, your blood vessel's natural protector, keeps vessel walls flexible, prevents dangerous clotting. Block COX-2, and you remove that protection. Simultaneously, regular NSAID use raises blood pressure 3 to 5 millimeters of mercury on average. 3 to 5 points sounds modest. Over 60, with arterial walls already less elastic, that chronic increase raises stroke risk in ways that accumulate over years. The FDA put a black box warning on NSAIDs in 2015, not just for stomach bleeding, specifically for heart attack and stroke. On the label right now, Clarence was taking ibuprofen every single day for 2 years. His doctor knew. Nobody flagged the cardiac risk. For chronic joint pain, ask about topical NSAIDs. Gels deliver the same anti-inflammatory effect locally, with 90% less systemic absorption. For chronic background inflammation, curcumin with piperine has real evidence. 2 to 3 grams of omega-3 EPA and DHA daily has better cardiac data than most people realize. The Reduce It trial. 25% reduction in major cardiovascular events with high-dose omega-3. That is a number worth knowing. Don't stop a prescribed anti-inflammatory without your doctor. The goal is a better conversation, not self-prescribing. Pill 3. This is the one that took medicine an embarrassingly long time to recognize, because it looks nothing like a cardiac drug. People buy it without a prescription. Take it with their morning coffee. Never think twice. Proton pump inhibitors, omeprazole, pantoprazole, lansoprazole. Roughly 15% of the entire American adult population takes them. Many for years, some for decades. Here's what gets buried. Your stomach acid isn't the enemy. It's a gatekeeper. You need it to absorb vitamin B12. Block that acid long-term, and you block B12 absorption. Not partially, almost completely. Why does a heart surgeon care about B12? Because it's essential for metabolizing homocysteine, an amino acid that when it builds up, directly damages arterial walls. Elevated homocysteine is an independent risk factor for cardiovascular events, comparable in some studies to high cholesterol, almost completely ignored in standard workups. A 2013 study in the journal Gut found long-term PPI users have B12 levels 30% lower than non-users, in a population already losing B12 absorption naturally with age. After 60, your stomach produces less intrinsic factor, drug-induced deficit on top of an age-related one. B12 deficiency looks like fatigue, memory problems, a tingling in the hands and feet that creeps in so gradually you barely notice at first. In severe prolonged cases, irreversible neurological damage. From a heartburn pill, taken for 10 years because nobody checked levels annually. But PPIs don't stop there. They also deplete magnesium, involved in over 300 enzymatic reactions in the human body. For the heart, magnesium regulates the electrical signals that keep your heartbeat steady. Deficiency is directly linked to arrhythmia, to cramps at 3 in the morning. Clarence's B12 came back critically low. His magnesium at the bottom of normal range, technically within range. So nobody acted on it. If you're on a long-term PPI, ask for B12 and magnesium levels. Ask whether there's a plan to eventually taper off. For B12, methylcobalamin, 1,000 micrograms sublingually, under the tongue, bypasses the absorption problem entirely. No stomach acid required. For magnesium, completely 24 milligrams, 400 milligrams daily. Far better absorbed than magnesium oxide found in most cheap drugstore bottles. Don't stop a PPI abruptly. There's a rebound effect. Acid surges back harder than before. You feel worse and go back on the drug. Taper gradually. Statin depleting CoQ10. NSAID removing vascular protection. PPI blocking B12 and magnesium. All three in Clarence. Simultaneously. 2 years. Nobody connected the dots. Each specialist saw their piece. Nobody asked what the combination was doing over time. 2 more pills. And these are where most physicians, myself included, had significant blind spots for years. Pill 4 involves a medication that prevents dangerous clots, while quietly accelerating something I've seen with my own eyes on the operating table. And pill 5? That one involves a recommendation I made myself. For 15 years, that the data now shows may have been wrong. I'll tell you exactly what I told my own patients when I finally understood what the data was saying. And it wasn't a comfortable conversation. Stay with me. Pills 4 and 5. Number 5 especially. That's the part that changed how I practice medicine. Pill 4, warfarin. Around since the 1950s. Still one of the most prescribed anticoagulants in patients over 65. Atrial fibrillation, deep vein thrombosis, mechanical heart valves. Warfarin is standard care for millions, and it works. It prevents dangerous clots. It prevents strokes in AFib patients. I am not disputing that. But here's what the 7-minute appointment almost never covers. Warfarin works by blocking vitamin K. But there are 2 forms of vitamin K, and warfarin cannot tell them apart. K2 activates a protein whose sole job is to prevent calcium from depositing in arterial walls and direct it toward bones instead. Without K2 activity, calcium drifts. It settles into vessel walls. Arteries become rigid and calcified, like pipes slowly filling with mineral deposits. Warfarin blocks K2 right along with K1. So while it's preventing dangerous clots, it simultaneously removes the body's primary defense against arterial calcification. A 2019 study in the Journal of the American Heart Association. Long-term warfarin users showed significantly accelerated coronary artery calcification compared to matched patients on newer anticoagulants. In patients whose doctors were actively trying to protect their cardiovascular health. As a surgeon, I have seen what heavily calcified coronary arteries look like. The calcification makes everything harder: the surgery, the recovery, the long-term outcome. Does this mean warfarin patients should stop their medication? Absolutely not. Untreated atrial fibrillation carries roughly 5% annual stroke risk. That is not a risk to dismiss, but it does mean asking 2 specific questions at your next appointment. First, given newer anticoagulant options today, is warfarin still the best choice for me? Medications like apixaban and rivaroxaban don't have the same K2 interference profile. Second, has anyone measured my coronary artery calcium score? A simple low-radiation CT scan gives a precise picture of what's happening inside your arteries right now. One of the most underused cardiac risk tools in existence. One scan tells you exactly what's happening. Changes treatment decisions significantly. Now, pill 5. This one is hardest for me to talk about. Not because the science is complicated, because I recommended it myself for years to patients who trusted me. I recommended it confidently, and I was wrong. Calcium supplements. If you're a woman over 60, there's a good chance at least one doctor has told you to take calcium for your bones. 1,200 milligrams a day. Take it with food. So routine it barely registers as a medical recommendation. It feels like common sense. In 2010, the British Medical Journal published a meta-analysis that stopped me cold when I first read it. 15 randomized controlled trials. Nearly 12,000 patients. Calcium supplementation without K2 and D3. 30% increase in cardiovascular event risk. 30%. A room of 100 women faithfully taking their calcium supplement every morning because their doctor told them to. Roughly 30 of them may be meaningfully increasing their cardiac risk, while believing they're doing something healthy. The calcium paradox. Supplemental calcium without K2 and D3 enters the bloodstream as a sudden concentrated surge. Your body doesn't know where to put it all at once. And one place it ends up is arterial walls. Same calcification we discussed with warfarin, but driven by the supplement itself. You take a pill to protect your bones. It calcifies arteries instead. Why haven't guidelines fully changed? Reversing a recommendation given to tens of millions of patients for 20 years is institutionally complicated. Liability questions. Industries built around calcium cells. Easier to add a quiet footnote than to say out loud, "We got this wrong." The first 15 years of my practice, I recommended calcium to elderly female patients. Routinely, reflexively. 68-year-old woman with early bone density loss, calcium and vitamin D. 1,200 milligrams. Take it with food. Every time. I was practicing exactly what I was taught. When I read that BMJ data, really SAT with it, I thought about every patient I said that to, every woman taking that supplement every morning. I felt responsible, not guilty. I couldn't have known what I didn't know. Responsible for making sure the next patient gets the complete information. That is why this conversation matters. That is why I'm making this video. If you're on calcium supplements, don't stop abruptly, especially for documented bone density loss. But bring this question to your doctor. Should I be taking K2 and D3 alongside my calcium? For most patients, the evidence-based answer is yes. K2 as MK7, 100 micrograms daily. D3, minimum 2,000 IU. Some patients need considerably more based on blood levels. And wherever possible, dietary calcium first. Dairy, leafy greens, small fish eaten with the bones. Supplements to fill gaps, not as the primary source. I've spent this video on what medications take away. Let me spend a few minutes on what genuine heart protection actually looks like after 60, because it's not complicated. And most of it doesn't require a prescription. Omega-3 fatty acids. 2 to 3 grams EPA and DHA daily. Reduces triglycerides. Lowers systemic inflammation. Helps maintain vessel wall flexibility. Magnesium. Chelated form. 400 milligrams daily. After 60, dietary intake drops while the body's demand stays constant. Supports heart rhythm, blood pressure, and sleep. Curcumin with piperine. Genuine evidence for chronic cardiovascular inflammation. Not ibuprofen, but for the background inflammation that silently drives cardiac risk over years. The data is compelling. Nattokinase from fermented soybeans. Shown promise for healthy blood flow and reducing excess fibrin that contributes to clot formation. Taurine supports cardiac muscle function. Aged garlic extract has meaningful data for blood pressure and arterial flexibility, both with long safety records. None of these are magic. None replace medication where medication is necessary, but they represent what the body needs to run well and what gets crowded out. Now, the one thing I want you to do before your next appointment. Write down every medication, every supplement, every dose, then write 3 words at the top. What am I losing? Every drug has a trade-off. You deserve to know yours. Statins lower cholesterol and deplete CoQ10. PPIs suppress acid and block B12 and magnesium. Warfarin prevents clots and accelerates arterial calcification. Calcium supplements